Buenos días, buenos días. Estamos
Good
abriendo la sala.
morning. We're opening the room for all participants at this webinar.
Ser bienvenidos, bienvenidas
Welcome you all,
y muchísimas gracias por
and thank you very much
estado
for having
en
registered
seminario sobre la
in this webinar
clasificación internacional de la
on the
funcionalidad
International Classification of Functioning,
y por vuestra
Disability,
participación.
and Health. Thank you very much for your attendance and
Ya veo que estáis
for your
utilizando el chat.
participation. I see you're using the chat
Buenos días. Os invito
to
también
say good morning. I also invite you to tell us what country you're joining from,
para ser consciente un poco del
so
alcance
as
y
to
de
be
dónde estamos
aware
llegando
of our
con este
reach
webinar.
with this webinar.
Muchísimas gracias desde Perú,
Thank you very much from
Colombia,
Peru, Colombia,
Brasil, México.
Brazil, Mexico.
Estupendo. Bueno, pues
Great.
yo creo que
Well,
vamos
I
a
think
comenzar ya con la
we
presentación
can
de este
start
webinario sobre la
with
clasificación
this
de la
webinar on the
Clasificación Internacional de
International
la Discapacidad
Classification of
y
Functioning,
la Discapacidad en Salud.
Disability, and Health.
Os voy a dar primero unas
First of
pautas
all,
para que
I'm
tengáis
going to give you a few
el
instructions
webinario.
to take into account for this webinar.
Os pediría a todos que tengáis, por supuesto,
Please
cámaras y micrófonos apagados durante
close
el
your
desarrollo del mismo.
cameras and
Tendréis abajo a la derecha
microphones.
un botón donde se
There's a
encuentra una
button
pregunta
at the right
que viene
bottom
apareciendo en
of
la
your
presentación. Es decir,
screen.
que este
It's
webinario
a globe
está
icon.
disponible tanto en
It's for
español como en
interpretation.
inglés.
This will
Podéis
be a seminar in both
elegir
Spanish and
el
English,
idioma
and
que
you can
queráis.
choose the language you
Bien.
prefer there.
Tenéis también justo a la
You
izquierda
also
el botón
have
de Q&A,
the
de
Q&A button
preguntas,
on the
de
left, at the
preguntas y
bottom
respuestas,
left. You
para
can use
realizar
it
algún tipo de pregunta
to
siempre que sea
ask
conveniente. Para ello,
questions
al final
if
del
you so
webinario,
deem convenient. At the end
aunque
of this
aunque
webinar,
sea breve,
we'll have some room.
os
It'll
dejo ahí
be
para
brief,
poder
but we'll have some
escuchar
room
vuestras opiniones, vuestras
to
preguntas,
listen to your opinions,
¿de acuerdo?
questions.
Bueno, pues ya son las 11:03.
It's 11:03 now.
Aprovecho, podéis
As I
comentar
said, you
desde
can
el
introduce
chat,
yourselves in the chat.
deciros quiénes sois,
In the
de dónde
chat
venís,
box,
de qué país
you
os unís.
can tell us who you are,
Y
what
desde
country
luego,
you're from.
gracias a todos por participar en este
Again, thank you all
webinar.
for
Os voy a
participating in
compartir
this
en primer
webinar.
lugar la agenda del evento
I'll share the
para
agenda
que
for this
quede
event,
claro.
well, so you have a clear idea
Vamos a ver si se ve la pantalla.
of what we are going to talk about. Can you see my screen?
Entiendo que sí, ¿no?
Yes, I understand you
Estupendo.
can
Bueno, pues
see
aquí
it.
tenéis la
Okay,
agenda
great. Well, this
y
is
la
the
vamos a comenzar
agenda.
con unas
We're going to
palabras de
start
bienvenida
with
a
some
nuestra
welcome
invitada,
words.
que es
Unfortunately, our unit head, Silvana Luciani,
entre otras
can't
cuestiones de tipo práctico
be
y
here
social,
because she has other
pues ha sido el
obligations.
encargado
So
de
I'll
las
be
palabras de
the
bienvenida.
person in charge
Y
of
a
welcoming
continuación
you
pasaremos
all.
directamente a
And
la
then we'll
participación
continue with
de
the
los 5 expertos que hemos
participation
seleccionado
of the
para
5
hablar
experts we selected
de
to
la
talk
clasificación.
about this
Tenemos a la doctora
classification.
Diana
We
Bendaño,
have
la doctora
Dr.
Grisel
Diana
Oliveira,
Ventaño, Dr.
doctora
Grisel
Karina Revirol,
Oliveira, Dr.
doctora
Karina
Patricia Moll
Revirol,
y la doctora
Dr.
María
Patricia
Alicia
Mosch,
Gallardo.
and Dr. Mayra Alicia
Y luego
Gallardo.
al final también
As I
dejaremos
said,
espacio para
at the end, we'll have
preguntas.
some room for questions and
El
answers.
webinario está previsto que dure aproximadamente una
The
hora,
webinar should
entre
last
las
an hour and a half.
12:20.
We should finish around 12:30.
Estupendo.
Great.
Muy bien. Bueno, pues
Very
damos
well.
comienzo entonces al
So
webinario
we're
sobre
getting
la
started
Clasificación Internacional de la
on the
Discapacidad, la Discapacidad en
International
Salud.
Classification of
En la región de las Américas,
Functionality
la
in Health.
implementación gradual de
In
la
the
clasificación ha
Americas,
supuesto
the
un hito
implementation of this
para pasar
classification
de
has
un
been a
sistema
milestone
médico
to go from a
a uno
medical model to
biopsicosocial.
a bio, psycho, and social model
Esto
of
nos ha permitido
disability.
ver a la
This has
discapacidad
allowed us to
no como
see
algo exclusivamente de
disabilities
la persona,
not as something
sino como
inherent
una
to
limitación a la
people, but as a
participación en
limitation
de la
to
interacción entre
participation
todas las variables en las que se encuentra.
coming up from the
Las cifras lo
interconnection
muestran, hasta
with
ahora ha
their
sido un elemento
environment.
clave en la
So
aplicación de
the
los derechos de las personas con discapacidad.
ICF is a key element in applying the
Desde
rights of
su
people with
nacimiento,
disabilities, helping them
políticas
to
y
identify their needs and
los
public policies and bills and allocate enough resources for people with disabilities. This classification started in 2001, and since then, PAHO supports its implementation to improve data, and particularly to know what is the impact of disability in a population that is more and more age. We are aware that we need sensitization and training and information schemes to incorporate the international data of functionality certification. We have 5 experts who will talk about the implementation of the international classification of functioning. I forgot to introduce myself. My name is Gustavo Perez. I'm a regional advisor in disability and rehabilitation of PAHO in Washington, D.C. Thank you very much for your participation. Thank you also to all the panelists who have kindly offered themselves to participate to provide you with a new vision and know how the international classification is being implemented in our region of the Americas. We're going to start with Dr. Diana Avendaño, who will talk about the clinical use of the ICF, sorry. Dr. Avendaño is a surgeon who specializes in rehabilitation. She has a master's degree in health sciences and epidemiology. She has worked in the Ibarra Institute from 2009 to 2015, and she has been responsible of international and domestic courses on ICF. She's also been an expert in the Mexican Center of Classifications, a collaborating center of WHO in PAHO since 2010, from 2010 to 2022. Dr. Avendaño, you have the floor. Good morning. Well, you know me. I'm Diana Avendaño. I've been introduced already. And let's start with our talk. Many of you know what is known as ICF. So we'll get started. We know that functioning is a general term including bodily functions, body structures, activity, and participation. It refers to positive aspects of interaction between an individual with a health condition and his or her context. Context can be environmental and personal factors. These are young people biking in Paso de la Reforma, Mexico. These children are healthy, they have no health conditions, and they are performing an activity of biking and participating in this cycling tour. This is functioning. The disability term is a general term including deficits, limitations in activity, and restrictions for participation. It refers to negative interaction aspects between an individual with a health condition and his or her context factors. They can be, again, environmental and personal. Here we see this person who has a health condition, and he has problems to walk. He has limitations for walking, and he uses a wheelchair to go about places. And to access this area, there are stairs, and that's the main barrier for them to participate. This is what we have to talk about, functioning in disability. The first definition is health condition. What's health condition? It's a general term including disease. It can be acute or chronic, disorders, trauma, and lesions. It can also include other circumstances as pregnancy, aging, stress, congenital anomalies, or genetic predispositions. Health conditions are codified using CIE-10 in some countries, and we're going to start using CIE-11. We see a heart attack here on the left. We have a neck tumor on the right, and pregnant women. They are not sick, but they have a health condition, or also, in this case, a trisomic child. I'm sorry, I can't pass. You can see the screen,
Sí, se
right?
ve la pantalla, doctora Bendaño, se ve.
Yeah, we can see it. Well, we're going to start with each component. The first one is bodily functions. These are system functions, including psychological functions. So you have physiology, uh, uh, connected to classification. Body structures are anatomy parts, as organs, limbs, and their components. And here we refer to anatomy, okay, the medical part, let's say. If there are any alterations, we'll call them deficiencies. An example here is a health condition is congenital cataract in this small girl, and the deficiency is in seeing, in sight, and the body structure that is compromised is crystalline here. So when we have alterations, we'll call them deficiencies. Um, Another component, the third one, is activity. Activity is carrying out a task or action by an individual. Here, there's this child buttoning up. He's getting dressed uh, on his own. Activity limitations are difficulties that an individual can have in performing an activity. Here we can see that while this child is using both hands to get dressed, this person uses only a right hand. Her leg is crossed because this person has an aphasia that is making it difficult for her to get dressed. She gets dressed on her own, but she does have a limitation. So it represents the functioning individual perspective. I mean, activity represents that. The other component is participation. This is the act of becoming involved in a vital situation. I explain this as interaction between the person and the environment. Here, we can see this child who has a health condition. He has a deficiency for walking, total limitation for walking, but he uses a wheelchair to move, and that facilitates his interaction with the environment. And there's a friend pushing him, and his friends are including him in play. So this child who has a health condition with deficiencies and limitations participates anyway. And also, we can see a flat floor. That means no obstacles for him. So it's easy for him to participate. Restrictions in participation are problems an individual can experience when involved in vital situations. This young child has a health condition, and his classmates are bullying him, are playing jokes on him, and there's a restriction for his participation because of this. This represent the social functioning perspective. The fourth component is environmental factors. These are extrinsic or external world aspects that make up the life context of an individual. As such, these players have to do with the physical world, services, systems, rules, and laws, and also people's attitudes. We have facilitating factors when they are present or absent, improve or um, uh, worsen disability. This young man is participating in school life, and that's thanks to his wheelchair, but also has a small table that can help him attend to class. Barriers are factors that, when present or absent, limit functioning and generate disability. This person in a wheelchair has a problem of stairs. There's no elevator here. So his movement is restricted. He can't go to the next floor. That's the difference between facilitating and a barrier factor. This is a clinical case, so we can use it as an example. We all need information to be able to diagnose if there's functioning problems or disability. Um, uh, to be able to assign a code to a disease, we need to have it diagnosed. If we don't have it diagnosed, how can we get information to be able to code? Because classification gives code to the information. We have to be able to analyze something. So this is a man, 57 years of age, with the following diagnosis. Um, right ankle arthrosis. His pelvic limb is shortened by 3 centimeters. This means the associated pseudoarthrosis, and this causes an injury in the right peroneal nerve that has been there for 30 years. He works as a part-time teacher, but he has to use stairs. He has difficulty to come up, and the right ankle becomes edematized, and it's very difficult to walk even if he uses a cane and a 2 centimeter um, compensation he has on his right um, shoe. All this causes severe restriction for giving class, and fortunately, he has his own car. Um, so he has promised to walk. There's an increase of the right ankle, 7 centimeters. There's edema. He has an equine position in his foot. He has many scars on the skin of um, this ankle, and there is a shortening of the leg of 3 centimeters, um, and there's a dorsiflexion of minus 40 degrees to 25, and plantar flexion of 40-40, and 20-30 abduction, and minus 20-20 abduction, right, left muscular strength uh, is at 4-5 on the hip, according to the Daniels scale, the knees 4-5, and ankle 0-5. We have applied the Hudas questionnaire with 12 questions. He got 47.1 is a score. His treatment was continuing to use his cane, using the 2 centimeter compensation on in his right shoe, and the use of compression socks and continue practicing swimming, an activity he carries out regularly. You can see here the X-rays. That pseudoarthrosis is consolidated. It took a long time to be consolidated, and you can see an arthrosis of the right ankle. And here we are underlining or highlighting in colors the different components. We have gray for the health condition. The next component is functions or deficiencies in functions, and we mark it in yellow. A tip here, functions will be found through physical exploration and lab studies. Altered structures are ankle and right foot and leg. Those are in green. Deficiencies for participation are found in red. And the environmental factors, whether facilitators or barriers, are highlighted in purple. His personal info, not classified by the ICF, but we have to take into account, are highlighted in light blue here. So I have the information. You have 1 minute, Dr. Avendaño. Thank you. Can I continue? You have 1 minute to finish. So the health condition is right ankle arthrosis, shortening of 3 centimeters in his right pelvic limb, pseudoarthrosis that is consolidated in the tibia and peroneum. Concerning functioning, moderate deficiency for walking, total deficiency of the right ankle articular mobility, total deficiency of this right ankle muscular strength, and moderate deficiency in venous return in that leg. Structured complete deficiency in that ankle, moderate deficiency due to the 3 centimeter shortening, and severe deficiency in the right peroneal nerve. Activity and participation, severe restrictions, as we showed, and moderate disability according to WODAS. Environmental factors, not using a compression sock, stairways. Facilitators are the pain, the right compensation, having his own car. We code it, and these are the codes that correspond to this diagnosis. We have to be specific. The more specific we are, the better the diagnosis can we give. And we can be more detailed in coding. Here we have up to 3 qualifiers, and they here we combine, for example, activity and participation, and here we say there are barriers or facilitators. It's a summary with an example of how to use this in clinical practice. Thank you very much for your attention. Thank you very much, Dr. Avendaño, for this excellent presentation. We are now going to the next presentation by Dr. Grisel Oliveira. She will talk about certification of disability based on the ICF. She's a physician specialized in public health. She has worked in public health and services. health services and also on ICF classification. She's also been an institutional manager, a professor at the Universidad de Buenos Aires and Salus and the Sciences of Rehabilitation and Movement Institute. He has worked at WHO, the Hispanic Network of Disabilities, and done consulting for WHO and other United Nations agencies. So I pass the floor to Dr. Oliveira. Dr. Oliveira, you have the floor. Well, good afternoon or good morning, depending on the country where you are. And we'll start with certifying disability based on ICF evaluation and determining of disability are the main access door of people with disabilities to getting support, services, and the care they are entitled to receive. Next one, please. The first legislation Argentina had on disability was in 1981, and it established a comprehensive protection system. At that time, it was called Comprehensive Protection for Disabled People, but now it's called with uh, a comprehensive protection of people with disabilities, and they ensured medical care, education, social security, also with stimulation and um, special rights, and the idea was to neutralize disadvantages in both sectors were health, education, labor, transportation, accessibility, and social security. The actors were state, health agencies, NGOs, and citizenship. In its second article, this law defined disability. And in the third article, it gave the Ministry of Health responsibility to accredit disability through a certificate. In 1983, we saw next one, please. We saw the passing of another law that certified disability through a classification, which was an attempt of WHO. In this process, it was focused on medical evaluation. This classification was taken by the WHO because in the 70s, we wanted to differentiate disability from incapacity or crippledness. In 2001, the ICF was passed and the Convention of People with Disabilities. And the preamble of this convention that you probably know, in the preamble of subsection E, defines disabilities according to the ICF version given us by Dr. Avendaño, and had two very strong issues. Argentina started to have a nationally valid certification. It was called single disability certificate. It used international instruments that are part of the family of classifications of WHO. The International Statistics Classification of Diseases and Health Related with Health, CIE-10, that allowed us to get to know health conditions. It was coded according to the information on morbidity and mortality. We know that we have to apply the new revisions that are already uh, current. And then there's this international classification of functioning of disability and health. That means when human functioning does not work, we talk about disability. Certification, according to what you want to call it, is done through an interdisciplinary board, an evaluation board, because the ICF, which has a biotype and social perspective, requires such a board. we can have all kinds of professionals in charge of rehabilitation, like physicians, psychologists, and social workers.
The evaluation takes place presentially, and it can be done also in a virtual manner. And the evaluation protocol is important because it has to take into account if we're talking about a certain person, it's the type and number of the identity document, the health condition. Well, that's generic, and then the condition that describes the functionality profile, and of course, there is a starting date of this health condition. And if this person has equipment and follows the protocol, he or she has, for example, a wheelchair or other means of getting around, and also education if he or she can read and write, and the institutional aspect, if the health condition has changed, and the necessary adaptations are taken. And there are also, of course, other issues regarding intellectual discapacity. If he or she lives alone, what type of dwelling, what type of home does he have? If there is running water, if there is sewage service, if there is electricity, and also the family situation, if he or she lives alone or has company of any kind in the living arrangements. With these aspects, we will set up the functionality profile through the SID and through a SIF, and it's, well, disability or this is a generic term and includes deficits and limitations of activity and restrictions for the participation and of this person in the context. And we have also studied this in detail in order to determine the person's functionality. There is a protocol, and there are some recommendations and observations because it has a national validity. It is valid in the whole nation, as in other countries also. And there is recommendations that have to be taken into account, and there is a legislation about facilities and also services. And there is, well, this certificate has to be signed and sealed by the interdisciplinary team. And public transport is free of charge. And it has to be determined if this person has to have a companion, and the validity, disability is dynamic, it's not permanent. For example, for a child, the certificate is valid for 5 years, and if the person is older than 6, then there has to be a new evaluation in order to see if this person needs it. And there are auditings at a central level, and also the signature and seals of the interdisciplinary team. The certifications in the country has allowed us to have a registry and a data system that is really clear and quite complete. And it's contained in the National Registry of the Situation of Persons with Disability. The information, the data includes the type of disability, the health coverage, social coverage, school level, social family situation, type of dwelling, and accessibility to means of transport. And if the person is less than 300 meters of public transport, then public transport might be considered accessible. More than 300 meters means that it's not accessible. Occupational level, if he or she is an entrepreneur or has a job, the social social services that this person has, for example, also a monthly subsidy or also the services he or she receives. It's important to say that the protocol for evaluation and what we can learn through CIF is to have a more complete idea about the situation of this person, if this person has certain characteristics and design means of support that are more personalized, and interventions also, for example, eliminating barriers. And also there's a promotion of inclusion and barrier elimination and access to rights and benefits and also employment and other services. The CUD, the Unified Disability Certificate, has to be requested or can be requested spontaneously if you want to acquire the benefits of the Argentinian legislation. You have to get the certificate. If you don't want to or you don't need these services, you don't need to have the certificates. I believe that it's very important to stress the fact that there should be a disability certification. It is really a health certification that applies a biological, psychological, social model. And it also, it emphasizes the positive element, and it uses a neutral language that is not stigmatizing and use in a common language that is of universally understood. We have to take into account that if each country could provide this type of information, this would allow us to carry on public policies because data is the most important factor to develop services and facilitates also the communication among different disciplines and the different sciences in the whole world. I tell you this as a physician, but it's not in our hands anymore. It's broader. It has a broader spectrum. Many of us talk about the convention, but few of us take into account this health classification that applies the biopsychosocial model. It's a universal perspective of human functioning. It includes contextual factors. It's not only about disability, so that it also emphasizes the positive element. And so in this case, the important factors about positive aspects have to be stated also in a language that can be understood by everybody, and it's in 14 languages. Regarding our experience in these last 15 years of using the certification, we can say that it's a tool that measures the reality. Its use derives from an international recommendation. The starting point is a health condition that describes the functional profile. It requires interdisciplinary efforts, and it allows us to describe the dynamics of disabilities. I hope that this will be useful for you. I want to congratulate PAHO for this great initiative. Thank you, Doctor, for this very clear presentation about the CIF and how it can be implemented. There will be lots of questions at the end, but we will continue now with Dr. Carolina Revirol that talks about the implementation of CIF in this digital world. And Dr. Revirol has a long experience in Argentina and other countries like El Salvador, Bolivia, Peru, and Panama in processes of certification of disabilities and training for rehabilitation also. And she supports us also in the development of resources and clinical assessments at PAHO. Thank you, Dr. Revidor. Thank you very much, Gustavo. I will share my screen. Here you can see it, my screen. It's right? Yes. Yes, we can see it. So thank you, Gustavo, for this invitation. And when Gustavo invites us to participate in this webinar, we all have a subject to develop. I will not talk about Dr. Avendaño explained. And so I'm going to talk about implementing the CIF in times of digital transformation. We will think together about this, about the digital world and CIF. And there is really a great trend towards CIF. And well, this is it implies generating data, and this data helps to deal with the subject because the care provided is also centered on the subject, and it favors decision making. I wanted to show you where we are with the CIF. We all know that CIF is published in 2001 through the resolution 2421, and it is starting to be implemented in the world in this year, 2001. And there have been updates, several updates, and although the milestones are not exact here, with the exception of up to 2007. Yes, please eliminate it. Yes, there was some text. There was some text at the margin. The 2007 is an important date because it led to publish a book with a good description of a very complete description of the CIF and ICF. And so PAHO starts to work on ICF, and we are now at the 11th edition, and it formalizes a process of constant updating of ICFS in terms of morbidity and mortality. And it can be implemented, ICF can be implemented in different electronic means. And there is a work group that was set up where we talk about functionality. And here, through this modernization and digitalization of information, we see that functioning is a registration it functions through a registration in the universal healthcare system. So we could say that today, to think about the implementation of the ICF, if a country starts from zero, we will not have versions on paper or books, but we will do it digitally. And we will use the last update of the ICF that is taken ahead by, that is in charge of PAHO, and with a different, and also through the WHO. And well, we will see here in the screen, here we have the classification. There is a code classification also, and I can use it with any computer or any electronic device. The ICF shares with all the modern standards the way of using electronic means. We can go to this site and look at this latest update for ICF, and for all the users, you should, well, recommend that you consider all the updates and different versions. And that's it. Okay. Now we can see it. Thank you. This is the screen. I will leave the link so that you can look it up. There are also there is a second level of environmental factors that I can codify, and that is kept updated by the WHO. And here we see this as a moderate barrier, but this code QRL code is generated. So this is a common language for this structured computerized language. And apart from the clinical history and the physician's information, we have to understand that the access to information in order to guarantee a better care, it also has to do with a biosocial point of view. So we adopt the digital version, and there is also, well, there is a universal application about human functioning, and we can identify not only disabilities, but there are different courses and taking care of a certain subject. We should add supplementary information in order that will interact with the other data. And I will keep data on medication, alerts, etc. All the the whole history, medical history of the person. And you can also incorporate an explanation about the functioning abilities of this person. But I have to say and sustain that although the ICF is a modern standard as any other I would like to use in health systems or any registers for work or health. So, for example, I want to identify the disability or the abilities, the capacities, but there is a cultural change implied in this when we register information. We have to fight against our barriers, because we have to register the information that is really useful. But when we add information about the functionality part, then we are adding data on the interaction between the subject and his or her environment, and the barriers and facilitators. And we have to, this clinical history of the subject would help us in the case of rehabilitation to in the care system to try to get an early detection and setting up goals and monitoring also the impact of our interventions or be able to change. And if we have this in an electronic registry, we will be able to get real data or real-time data on a medical condition. And this is not only when I identify the disability, I have to incorporate the evolution and the functioning factors as part of the health state of the subject. And we have to work at this in an interdisciplinary manner with all the standards that are used for registration. And what would this allow us to do in the health system in general? If I have information registered about the functionality of a person, so I can have, in case of an emergency or an emergency, I can know what the disability level is and find out where the greatest problems are. And I know where this person lives and the needs for adaptation. And I might need special care. For example, if this person comes to an emergency at the hospital, comes to the emergency service, I would need to have access to the data about this person. For example, not only the clinical history, but also his present state. And this is one of the advantages of a structured registry because it allows a better monitoring and the specific needs so that it's not only a medical or biological point of view, but also how this health condition impacts the functioning in society of the subject and allows for monitoring and follow-up. I want to show you a project, but I want to install it here because I believe that all that are here are interested in this project. And then, of course, there will be certain spaces where I have to register the specific disability, but it is part of the evaluation of a subject at the health system with different levels of interest. There is one problem that came up, and I will tell you very quickly. And there is one problem in the European Union and other countries that needed to implement the right to health services, um, and the information had to go over the borders, because if a person lives in Spain and goes to Portugal for vacation, Portugal also needs the data about this person, so they have to understand the needs of this person, and it's a problem in reality, and we have to find means to overcome this problem in the framework of human rights. So a series of standards were put together, and I will tell you this like a little story, because it was said, okay, let's set up a standard, and we need a minimum structure of data that could be read by anybody. It could be with a QR or any other link, and the person should travel with that information. And this has been developed already, and it's easy to implement. And we're working on structuring this. In Latin America also, I will mention it, there's a project of the digital health highway, and there's even information in order to have a um, better access to the data, to this data. And what we need to know what barriers, limitations, and restrictions this person has, and how we could identify his or her needs. And the latest publication of ISO starts with the recommendations for this standard. The structure includes a minimum data about the person, and that um, we would have to include physical and mental functioning. It's a project that started in 2014 in the Americas. This project of the digital highway will become a standard, and I believe that the CIF is the ideal standard to incorporate information about the functioning of a biopsychosocial point of view. We will include um, information about mobility, daily life, restrictions, etc. And we can be part of this initiative, and it would guarantee that this is in general registered in the health system. So I would love to that we work together on this. And after all this storming, well, Gustavo said we shouldn't leave aside the artificial intelligence, because there are science news that go through all the means of communication. I'm using AI a lot, and uh, we can use the AI to facilitate all the registration on paper, everything that is in in a former uh, phase. For example, we have to sometimes people use, or the systems use different terms. For example, wash oneself, or take a bath, or um, carry out the hygiene habits. So there should be a we have to overcome the restrictions between professions in order to share our common view. And for the implementation, for all of you that have it implemented, you have a universe of possibilities to have dashboards and markers, etc., so that you can transform it in population data, in individual monitoring, in order to identify the disability in the registry, the clinical registry. So if there are these characteristics, this means that this person has a disability. And well, I leave you the information. And the registration to the ICF transforms the process of care in a system centered on persons and based on objective data about the functionality. It allows a better, more inclusive, more coordinated, and evidence-based care with clinical and organizational and public policy benefits. We need indicators, etc., that allows us to monitor the health of state of our population. Thank you very much.
Muchísimas gracias, doctora Revirol, y muchísimas gracias a todos los
Thank
participantes.
you,
Disculpa un poco el ritmo que llevamos, pero
Dr. Ruirol. And it's very interesting to listen to all of you, and this provides us a lot of energy to continue working.
Patricia Mosh, ¿de acuerdo?
We now have Dr. Patricia Moore, who is going to talk about the relationship between SIF and healthy aging. She is a colleague at PAHO. She has more than 19 years in clinical care, physiotherapy, public health, and aging, and she has a gerontologist master degree. She works as an advisor on aging at PAHO. Patricia. Thank you very much, Gustavo, for your presentation, and thank you very much for this invitation. I'm very glad to be here at this event and be able to work interprogrammatically between different departments and units at PAHO and coordinate the work we need to coordinate in the country, with the country too. Well, this is my presentation. I'm going to talk about the relationship of ICF and healthy aging. I'd like to pay homage to Dr. Enrique Vega, who recently died, our PAHO colleague who was for several years a regional advisor on healthy aging and more recently in the course of life unit. So this presentation is also for remembering him in our region and the world. I have to talk about healthy aging because there is an important demographic transit or population transition in our region and the world. We have a decrease in general population of younger groups and an increase, an expected increase of people who are 60 or more. This increase of 60 or more people is particularly important in the Americas and particularly in Latin America and the Caribbean because we have very fast aging. In this group, we must highlight that those who age more in more accelerated way are people with 80 years and more. And this population group has more needs in terms of care and rehabilitation due to their vulnerability. I must highlight also that populational aging happens in different ways in different speeds and countries. So in many countries in the region, we have already aged countries, but not all of them. However, they are all on this path, and we have this window of opportunity of getting ready for population aging. It's important in our work. Also, in this context, we show that we have more people aged more than 60 than children under 5. And we expect that the elderly will be more representative as compared to youth younger than 15. So we must highlight that people live more, but not necessarily live with more health. There is a gap of approximately 12 years in the Americas between life expectancy and healthy life expectancy. And this gap is even more significant among women. Women live more years, but they live more years with chronic diseases and disabilities that do not favor good health when aging. So our commitment is that these years we add to our life expectancy should include more health. A big milestone in the work of healthy aging at PAHO was the publication of the Global Report on Aging and Health in 2015. This is a framework for our work. Here we develop actions that led to the approval of the action plan on aging and health and also the decade of healthy aging. There are very important points we need to consider in this report. First of all, we must understand what we consider as healthy aging because most elderly people have chronic diseases and problems related with physiological and biological aging changes. So it's fundamental to remember that health trajectory during aging is complex and dynamic, and these elements, as diseases and multi-morbidity, will directly impact physical and mental capacities of people, their functionality. Therefore, and because of the impact that all these situations have on functionality, we use functional trajectories to predict health results in the elderly. And all of this is reflected in this report. and also how we should work towards this perspective, functionality. And all this was based on the ICF. So it was possible to achieve these definitions for healthy aging. So, as from this report, we have considered healthy aging as a process to foster and keep functional ability that allows for well-being in old age. Functional ability are attributes related to health that allow people to be and to do what they value. And this is a positive approach. The approach focuses on abilities and capacities. And we talk about interventions. We have to identify losses to act in such a way to favor functional stability. But we always look for a more positive view of abilities in the elderly. And to be able to achieve functional stability, we consider two fundamental components. One is their intrinsic capacity, all the physical and mental capacities in the person, and the environment, because the environment is where people carry out all their activities. And also, the environment has direct relationship with intrinsic capacity because it can model what a person with a certain intrinsic capacity level can do. The domains we consider for functional ability go beyond daily life. They're also related with participation as in the ICF. So being mobile, learn, make decisions, satisfy basic needs, and have basic relationships and contribute to society. Many have included the purpose and objective so people can achieve all these together, jointly, in a joint way. And intrinsic capacity domains were also included in the ICF model, looking to the positive attributes in the elderly, considering cognitive, psychological, sensorial, vision and audition, vitality, energy level, nutrition, homeostasis, and mobility. And their different levels. Also, considering the ICF context for this model, activities are considered as a product that people with a certain intrinsic capacity level can develop in their environment. This positive vision helps fight stereotypes and age use we have concerning the elderly and aging. We consider that the elderly have different functionality trajectories, but also different wishes, objectives, and tastes for their lives. So the concept of functional ability allows us to promote health and well-being, starting from all of this in their heterogeneity. At PAHO, we have lots of tools and strategies, always looking to optimize the elderly's functional ability. We have this perspective of favoring a continuum of care for the elderly in their different uh, functionality degrees. We understand there are fluctuations and that these trajectories are dynamic. Um, in this healthy aging model, we consider the elderly in three large groups for monitoring, decision making, and high and stable capacity with capacity deterioration and with considerable loss of capacity. These former ones are considered in the group of people with long-term care needs. Among the tools we have for technical cooperation and for countries to progress in this healthy aging model, for clinical care and health in the elderly, we have the ICOPE model, comprehensive care for the elderly. It is based on primary health care, and we consider community and social issues with care routes based in their capacities to support communities and these actions. We have a program portfolio that are based on evidence and promote community collective actions for developing these intrinsic capacity. We consider the environment in the friendly uh, communities and cities for the elderly. The Americas has the most members in the global network at WHO. 17 countries participate, almost 1,000 communities committed in creating environments to favor the elderly's capacities. And we also have models for creating and strengthening care, long-term care in the Americas, and particularly emphasizing the role of the health sector in care. Traditionally, in our region, these are services that are organized by the social sector. So it's fundamental because the elderly that need long-term care have significant health needs. So the health sector and its involvement is fundamental. And of course, we have opportunities to work together as from implementing the ICF and the framework of healthy aging. It allows us to implement a biopsychosocial model comprehensively focused on the person and his or her needs, and the implementation of the ICOP model in friendly cities favor, of course, this healthy aging. And we also have uh, ICF that helps us understand the perspective of monitoring and needs beyond the clinical model based on diseases. Most social determinants of healthy aging can be defined by policy. So we have an opportunity to foster uh, healthy aging trajectories stemming from these changes. And this graph shows that intrinsic capacities that are mental and physical decrease with age, as we can see in the dotted line. But we do have strategies and intervention models. So we have appropriate actions that allow us to keep functional abilities at a good level so these people can live with more quality and independence. And finally, I'd like to highlight that we are at an important point to carry out these actions. We are at the middle of the healthy aging decade. We have many achievements in the world and the region, but there's a lot of room for improvement. So I invite you to partake in this decade in movement of all of us. I leave our website on healthy aging if you want more information and get to know those documents in more detail. Thank you very much. I see Gustavo has the screen. So my time is over. Very well, Patricia. Perfect. Thank you very much. And very interesting how the ICF together with healthy aging can be uh, key tools to help us with diagnose and also contribute with solutions. Wonderful presentation. And we'll finish with an important point, which is really practical application of ICF, how we take this classification, how we implement this classification and share good practices, thanks to the Salvadoran Institute of Rehabilitation, led by Maria Luisa Gallardo.
Dr. Gallardo is a physician with a special decision in rehabilitation and public health. And she has worked at hospitals and has been also in charge of courses of all kinds about functionality and health. And Dr. Gallardo has also been part of the Social Security direction of El Salvador, and right now she heads the Salvadorian Institute for Rehabilitation. So after Dr. Gallardo's presentation, this webinar will be finished, and she will explain to us how this tool is essential, not only for diagnosis, but also to get to know the needs and to get to know the policies that have to be implemented in the countries. We all know that it is very important to gather data, and Dr. Gallardo will help us with that. Um, Good morning, everybody. Thank you, Gustavo. I would also like to greet our dear friend Armando Vasquez, and I will share with you our tool. It's an experience we have gone through. We have had a lot of support with the IDB and also PAHO, of course, and we wanted to turn our third level institute for rehabilitation into something that could measure the impact of our rehabilitation efforts. Please, could you adapt your presentation to the full screen mode, please? Well, I could start with the fact that the institute is an institution of third level rehabilitation. Is that okay? The screen is okay. Yes. Okay. So it's part of the comprehensive health system in El Salvador. There are 8 specialized centers and are distributed among the main areas of the country. And we also have a space for patients that stay at the institution overnight. And well, we wanted to implement all the mandates of the WHO and we at ICF. So we have created a rehabilitation system with ICF, where our user comes to well, it's classified according to the category. Or maybe the person is not here for rehabilitation. It's a way of saying if this person requires rehabilitation, we have to define that because it might not be necessary. So this rehabilitation will be provided to people who really need it. And so the person comes for evaluation by physicians and a psychiatrist, and we have, of course, this evaluation sheet of ICF, and we also have to take into account the perspective of what the patient desires. As our colleague said, we have to start also from the general health condition, and we will describe in a free text the structure and abilities the person has in the initial sheet of the patient's chart. And so this patient will go then to different programs. It will not stay only in one or two. And we have the rehabilitation for mobility functions. We have also a program for visual deficiencies, mental deficiencies, and also the program for labor training, etc., for work training. And so we have developed functionality programs. We have put this together in a multidisciplinary approach, and we have defined that these are the categories that our program needs. Of course, we can acquire new ones. There might be changes, or there is a permanent effort to improve our services also. We can add categories depending on the need. And it's also important to mention that all the rehabilitation tools, for example, muscular strength, measuring of sight and hearing capacities, etc. We have them at all establishments of the ICF with the ICF standards. And so when we are evaluating a person, we know that we will use this ICF scale that we all know, of course. I don't want you to read this because you will be able to see it, but this is the functional profile for human communication. We have defined it this way because it's children that come to our institution as a majority, and we have to define the disabilities and also the WHO interventions that can be carried out. So this is for example, a child that has a moderate hearing problem, and so we start with the evaluation, and this was the first part. For each program, we have created the objectives. We have set up the goals, consensual goals, and then these are the goals we want to reach when when a patient comes in with human communication problems. In this case, it would be we need to rehabilitate this child that can also have problems for speaking because he doesn't hear very well. And so first of all, we have to understand, speak, hear, and deal with voice problems. So, and there are other spaces here on the chart because we can define further objectives, further goals to reach that we will also talk over with the parents of the child or the person, the adolescent, the teenager, or the adults. And of course, we are very keen to establish an interdependence. And in this case, with problems for human communication, there are certain categories of the four components of ICF. And the first evaluation, we set up categories. There is the whole profile, and we will use the categories that in this case we're going to use. For example, the functions of hearing and understanding and psychomotricity, and we will evaluate the patient according to the ACF scales. And we have set up here the different color bars and a level 2. We have come to a level 2 impairment, and was the initial evaluation, and then there is a screen that says follow-up and also a final follow-up, a final evaluation. For example, sometimes they spend about 3 or 4 years at our institution for rehabilitation, and we can see if the goal that we have set for ourselves, if we are making progress towards it, and then we have the bodily functions in general and the structure of the body for this child and the participation we want to have in her process of rehabilitation. Of course, we have also, of course, classified her performance as a level 3. So it's not really very high, there's not a great difficulty. And so we can also state if the initial goal was reached, and we do a follow-up. And we continue classifying, and we see that the green bases, we hear the green chart, the abilities are sort of stationary. We see if the abilities are stationary or have been evolving. And there are also the same factors that are assessed. And we want to know what the main barriers of this child are and what we can do for her in order to rehabilitate her. And finally, after the assessment, well, this child has not finished rehab. She's still in the process. But I wanted to show this to you because this shows how the process is going on. And we also have statistical data because we need real data, and ICF allows for this. And so we can see if we are having a good impact with our rehabilitation measures or if something is missing. In the case of this child, our main objectives are are making progress. She hears better, but she has still she has still speaking difficulties, impairments, and also comprehension problems. And so we are in the process, but we still have we have 33% of progress in this rehabilitation. And here we see how the environmental factors, the facilitating factors, may help us to make progress, and we have a good context, as it was said. Well, in rehabilitation, we have a context that we cannot improve, but we can at least have the data so that the Salvadorian state can have this basis, the database, in order to focus on the most common problems or act where there is greater limitation or need in the population. So our challenge is this one. We have to have data about the functional impact of rehabilitation on patients, because this will allow the recollection analysis of data for the visualization of functional needs of the population with disabilities. And with this, we will have administrative registries at the Institute that can be used by the Salvadorian state to do a follow-up, and also do a follow-up of the policies that are already in place, such as growing together and the law to be born with affection and care, and to establish more inclusive policies. This was what I wanted to share with you. Thank you, Gustavo. You have respected the time allotted because it's exactly the time when we have to finish. But so we won't have space for a Q&A, but it was worth it to listen to these 5 experts. I have seen many questions, many of them very interesting, and this leads us to know, this helps us to know that, well, there were more than 1,000 people registered, but the platform allows for the space for 500, so we have to go ahead with it in the same way and help to, and all of us need to learn from the experts in the region. And so we need to take this tool as a fundamental tool to know about the disabilities of a person and how to establish an equitable, egalitarian structure to allow access. And it's a great challenge, and we are at the point where we can visualize how the tool can be implemented in all the health services in the Americas. I would like to thank all the speakers for their excellent presentations that have been full of novelties and news, and of course to thank all the people, all the persons that have been present at this meeting. In the next days, we will send you the recording of this webinar, and we can share those presentations that can be shared, and you will receive them by email. And thank you again to all of you, and also the technical support of the IP colleagues and our interpreters. Thank you very much, and until the next meeting.